Good evening, everyone. Welcome to our presentation, Case Conceptualisation. Just as we're waiting for people to log in, I'd just, if you could just add into the chat where you're zooming in from. The second question, just as we're waiting for people to come in, what would you like to get out of tonight's presentation? Great, thanks everyone. So for you that are still just joining us, just asked you to put into the chat response to two questions. Where are you calling in from, and what would you like to get out of this session? We've got a little under an hour together tonight. Yeah, some people are asking for a refresher and different perspectives, recap and streamline, how to do handover. We are recording this for some people that couldn't make the recording. So if you don't want your name or visual, please just turn your camera off. We won't. We're using mainly slides, and when we come to question and answer, we again, when we come to question and answer, we'll turn the slides off then. And if you don't want to be seen, please just turn your camera off. But feel free either to ask questions in the chat or to speak out during the presentation, or we'll give plenty of time at the end for question and answer. Just to introduce ourselves, I'm Nigel Denning. I'm a counselling psychologist and Director of Integrative Psychology Medicine in East Melbourne. I've been working with Trail for a number of years, and yeah, very, very interested in how we learn to conceptualise and formulate in this work. Been an interest of mine for a long time, and we've applied this work in a number of different settings. Some of the training that we are involved in involve adult attachment repair and psychedelic psychotherapy, amongst some of our areas of interest. Trail, you might like to introduce yourself.
Yeah, hi everybody. Thanks so much for being here today. I'm really looking forward to being able to share with you some thoughts about case formulation, and also hopefully get into some discourse and answer any questions you might have. As Nigel said, my name's Trail. I'm an associate professor in psychotherapy, and I've been involved in this work for a very long time. This is a little pet project of mine. It's been running for about 15 years. So Nigel and I have been working together for about that amount of time as well. As Nigel said, delivering other trainings, and I guess we see one of the unifying factors across all forms of practice, people's capacity to formulate. So hopefully today we'll begin with some problematization around the question of formulation based on current research and evidence, and we'll also then have a lot of time to just address your questions about formulation and see if there's anything we can help you with. So you can leave here feeling like you've got what you were hoping for. So thank you.
And just a thanks to Gina, who's working in the background to keep everything running and keep us in line. So thanks for all your hard work and commitment, Gina. So next slide. So just in general terms, good conceptualization has two very broad purposes: to make the client feel seen and understood by the therapist, so that we really kind of embrace their story and their personal journey, as well as understanding the nature of their problem, which, when done well, leads to guide us to a more accurate treatment planning, to apply technique and skill to the particular personal needs of the person we're working with. Next, please. And this is a great story from Trail worked for a number of years with Professor Graeme Smith. So I'll go over to you, Trail, to tell us a little bit about the origin of some of this work.
Yeah, so the work we'll be addressing today came out of, I guess, an important period in my clinical training and development, where I spent a number of years with Graeme Smith in the Department of Psychiatry at Monash. And when I was doing my PhD in psychiatry, I was dealing with a very particular set of problems around case formulation. One of the case studies in my PhD was really perplexing and was very hard to make sense of. And I don't know if anyone here had the privilege of working with Graeme, but he's a very well-known figure as the head of psychiatry at Monash for many years, and was a very lucid and clear thinker. And it for him kind of signaled an opportunity for us to return to something he'd been focused on a lot in his work, which was the question of formulation. Formulation is, the most failed component out of psychiatric examinations, and there's a whole kind of period of work there where we spent, I want to say 3 or 4 years, doing a systematic review of all the literature in the field. And what we were really searching for was a common factors approach. So we're looking for the common factors that comprise good formulation across the disciplines of medicine, psychiatry, psychology, psychotherapy, counseling, and really trying to figure out, well, what is it that makes a good formulator? And just before Graeme passed away, we were actually working on a publication that I haven't finished yet, which was entitled "What Does a Good Formulator Look Like?" And so this has been a long-standing project. The results out of that period of time created a number of very important articles that were published in psychiatry, and a number of book chapters that went into some important psychiatric texts. That material was kind of also used in the Masters of Psychiatry at Monash for a little while. I'm not sure if it's still in there, and I implemented it well at the institute that I teach in for the case formulation practice there. So this is the work that we're going to share with you through this training and through this process is one that comes out of I guess, a long-standing effort. It's not something that just appears from nowhere.
I think what struck me too, Trail, is kind of Graeme's recognition of there have been problems in being able to formulate at the end of psychiatric training.
Yeah, well, across all training, Nigel, it's interesting. We've delivered this training to psychiatrists, to psychologists, to counsellors, to social workers, and it's a pretty ubiquitous problem. Is the capacity to kind of think clinically in a meaningful way, and that's not a criticism of the people who struggle with it. It's rather to highlight how difficult it actually is as a task, and that what we really need to do is figure a way of kind of teaching it and sharing it in a way that allows clinicians to develop more competency in that. And we'll talk to some of the problems as we go through tonight.
Thanks, Trail. Next slide, thanks. So yeah, do you want to just maybe say a little bit about the nature of case conceptualization, Trail? It's such a fundamental feature of our work, but I'm not sure that we share a common language around it.
Yeah, look, I mean, formulation is without doubt the cornerstone of effective treatment. I mean, it's the basis on which treatment plans are developed, and we know that more focused treatment is more efficacious treatment. We know that if we're really thinking about formulation, it's the thing that makes various forms of psychological practice a conceptual and theoretical endeavor. It's the thing that draws all of that work together, and it involves forming and building a hypothesis around causes. But there's another way of looking at that, and this is the way that Graeme would always frame this up in our work, was that it's essentially almost a kind of clinical koan. Why is this person presenting in this way at this time? This becomes the kind of the essential kind of question that we're trying to ask when we're building a formulation. And despite it being so important despite all the work that's been done in research on it, it continues to be a problem for people, Nigel.
Yeah, and I think you struck the nail a little earlier. You know, the common factors approach, really starting to think more about the subjectivity of the person, the complexity of the person, rather than solely the nature of the symptoms. It's really a very much a human-oriented way of working, isn't it?
Absolutely, absolutely. I mean, the purpose of a formulation in real terms is to increase your understanding of the person you're working with. And explanations don't by necessity increase understanding. There's often a tension between explaining and understanding. And so an explanation is only of value to the degree to which it increases our capacity to understand the subjectivity of the patient. And that's really, really important.
Yeah, and as we say, it creates that compass for the therapist to steer through the relationship across time.
Mm, exactly.
And there are problems in case conceptualization, as you discovered in interrogating the literature and surveying the various fields involved in.
Yeah, yeah. Even though everybody will use the term formulation or conceptualization, there's no unified definition. And indeed, you know, though we find a kind of proliferation of completing descriptions, you know, sometimes what formulation is can be incredibly complex, algorithmic work, and sometimes it can be just incredibly vague. And sometimes it can even be something as simple as the treatment plan or a diagnosis or inventory of symptoms, as if that constitutes a formulation. So when we use that term formulation, it's covering a multitude of explanations, and it's really important for us to try and get kind of some clarity about what we mean when we're talking about formulation.
Yeah. Next, please. So yeah, as you've already said, you know, there are problems around defining conceptualization and formulation, and a lot of people would see it as very much technique specific or model specific, I believe.
Yeah, yeah. I mean, so there are various approaches to formulation. So there's a number of different generalized strategies to formulation, and on top of that, there's discipline-specific formulation. So, for example, you know, someone with a psychodynamic background will work very well often at being able to formulate in a psychodynamic register. Someone in a CBT background will be able to do that. But there's a whole bunch of different questions here. If we look at the literature, sometimes the language is between horizontal and vertical integration, you know, and one of the challenges is how do we find a mode of formulating that allows us to draw various levels and registers together in a meaningful way. And that's a challenge which, you know, we really haven't got an answer for yet clinically.
Next, please. So some possible definitions of formulation. It's hypothesis making about causes and the maintaining of influences of a person's psychological, interpersonal, and behavioural problems is one. A process of linking a group of data to define a coherent pattern that helps to establish diagnosis, provide for explanatory explanation, and prepares a clinician for therapeutic work and prediction. Formulation is beyond diagnosis to include an understanding of the whole person, their problems and their causes. It could be a blueprint guiding treatment, supporting empathy and managing ruptures. Anything you'd like to say there, Trail?
Yeah, I think those are all good explanations of what formulation does, but in some ways they lack an important component of it, which is that formulation is a capacity that's built into the clinician's capacity to think and feel in certain kinds of ways. And one of the big problems with formulation is, of course, people just want a template to formulate off, versus, you know, really developing the capacity to think clinically and be able to develop what we know from the research are the characteristics that make up a good formulator. So capacities to think both intuitively and analytically, to do those things in relationship to each other. These are very important components of formulating well. So these are good definitions, but they kind of lack what's really important in order to become good at it.
Yeah, it's a complex task, isn't it? Next, please.
Really complex. I mean, Nigel, I think that's one of the most important pieces to remember, is that it is an attempt to form a reduction of the most complex thing we know about, which is another human mind. And so it's always going to be a problem. It's always going to be an incomplete event. It's never going to be totalizing. And it's really important to hold that in mind.
Yeah, thanks. I've got a question here, Trail, from Graeme, who asks, say you were treating a client with a DSM diagnosis of depression with CBT, how would different conceptualizations differentially impact CBT treatment?
Yeah, so really simply, I mean, if we think about a corresponding mode of practice, say we are thinking about a psychodynamic approach, depression is normally split into introjective and analytic formations in psychoanalysis. So immediately formulating within an analytic framework gives a whole different perspective on the nature of the depression. Is this an analytic depression, which is born out of primary lack, essentially, or is this an introjective depression where one's early life has been exposed to criticism and hostility that person has placed into themselves? That distinction is made very famously by Sidney Blatt, and that makes a huge difference, but of course, there's very advanced ways of formulating depressive symptoms within a CBT model as well.
There are multiple models of therapeutic approaches that have their own conceptual modeling, CBT, ACT, DBT, IFS, for instance, and each model has its strengths, but the sheer volume of possibilities out there for clinicians can be quite overwhelming, can't it?
It can be, and it regularly is, and often clinicians feel like they need to be across all these different models in order to treat someone, and that in itself is a kind of bewildering pressure that clinicians can feel. The truth is that in real terms, what might sound like rich diversity often results in kind of fragmentation, inconsistency, superficiality. It often presents in people not really forming things up very well. And so one of the things that we would say is that it's not that there are right models or wrong models, that someone has it right and someone has it wrong. All of us come with differences in our training and our perspectives. And really what we're trying to do here is go, is there a common set of features that moves across all forms of formulation that we can apply for everyone? So a CBT practitioner, a psychodynamic practitioner, an IFS practitioner, whoever it is, could actually get better at formulating. And really importantly, the question of integrated formulations becomes important. Like, can we help people develop really integrated hypotheses formation where they're able to use multiple systems, which often have contradictory assumptions in them? So how do we engage in what they call syncretic thinking? How do we draw these theories together in a meaningful way to help us create better understandings of people? Because the reality is that most human beings are never completely accounted for by a singular psychological model. And so we often have to draw on multiple models. And of course, Prochaska and Norcross and, all those guys have spent a lot of time trying to think that problem through.
Theoretical work. But with that kind of CBT-based conceptualization around depression, what we would typically utilize there would be an explanation of the way in which automatic thinking would be affecting someone's mood, and the conceptualization would really be around conditions specific to the treatment. How else from a CBT model might we conceptualize?
Yeah, well, I mean that's the nub of what's being involved. Obviously, is kind of thinking about it in those terms. But of course, CBT has lots of diversity and complexity in it as well. So an ACT model, which is a third wave CBT model, is going to, be very different to, the traditional stuff established by Ellis or someone like that. And so it's really important to recognize that. And, there's a lot of research done within the cognitive behavioral kind of models for very specific disorders that use very, very particular forms of thinking. And that's not a bad thing. I certainly would never criticize that as being a bad thing. But what the research shows us is that people need to develop something more than what they've been getting.
Yeah, thanks, Joel. Further question, don't specific treatment modes like DBT come with a built-in conceptualization? For instance, with DBT, it's the biosocial model, biopsychosocial model, a more sensitive person being raised in a fairly austere family environment, for instance.
That's absolutely true. And that is exactly the point. I mean, if you take kind of Engel's original project with the development of the biopsychosocial model, he was trying to come up with a way of helping clinicians think more diligently about, subjectivities, but also, systemic dimensions of practice. So yes, nearly every model of therapy, this is the point we're making, has its own prescription about how to do the formulation. But what we'll find is that there is an underlying set of qualities that clinicians can develop that will make them both better at that, but also help them improve to formulate across disciplines or across models. So there's a twofold benefit to that.
Another question come in from Kuan. Is schema mode mapping a form of case conceptualization or still considered an incomplete way to formulate? That's a great question around a more recent development in the CBT family.
Yeah, I mean, I think that it's not a formulation. It's not a formulation. It's the information or the data that's being gathered to generate a formulation. The quality of the explanation doesn't by necessity follow immediately from the mode mapping, but it might point to or hint towards something that is important. And what you'll see there is there's an attempt within a cognitive behavioral model to help try and form some ideological kind of descriptions about why these things are there or how they've come about. And those are important dimensions of all clinical work.
Thank you. Next slide, thanks. One of the problems with conceptualization is the way in which clinicians may approach it and contemplate their own kind of practice. And research, I think, tells us that taking our own perspective may not always be the strongest way to approach the work.
Well, I mean, the research into people's capabilities in formulation is not particularly positive. So if we look at the research evidence into this domain, when people try and assess the quality and the accuracy of formulation, it's often quite low. You can see here there's some, we've included a couple of papers, where they're comparing kind of characteristics or abilities. You've got, this 13% difference in first year trainees versus doctoral trainees. I mean, this other number here, this 5% difference, is an extraordinary piece of research where they compared psychiatrists and clinical psychologists with the powers for involuntary admission, and they put them head to head with engineers, and there was a 5% difference in the accuracy of diagnosis and formulation capabilities. So it's a really important area to recognize that it's actually about developing a certain kind of set of capabilities within the clinician. It's not simply a matter of telling them, here are the symptoms and figure out how to apply this, or here's the model, figure out how to apply this. There's a number of other things that we really need to develop in order to make that meaningful.
David Rosenhan's classic study from the 70s where a bunch of students feigned mental illness to be admitted into a hospital, only to a few days later explain to the staff that they were in an experiment. The staff failed to believe them. And it took the supervisor or the lead theorist to come along and convince the hospital staff to release the students.
There's an interesting question there about would you incorporate culture into your formulation or conceptualization? And the answer to that is absolutely yes.
Right.
We spoke just briefly about Engels' biopsychosocial model, which has largely been taken out of a lot of the DSM and things like that now. But the importance of culture highlights the questions of vertical integration, where we want to be including both biological, psychological, and also cultural, social factors into our formulation. So yes, that's an incredibly important part
It's
of.
one of the most critical, isn't it? Because if we listen closely enough to the subjective experience of someone, we don't make all of those cultural kind of colonial errors in imposing our view, our concepts onto the mind of another. And people are coming from so many different cultures into Australia where we're working, attuning and really listening and understanding the nuances of their experience in the world um, means everything to understanding appropriate treatment and targeting appropriate treatment.
Exactly. It's a great point, Nigel.
Maud, hi, how you doing? Good to see you again. Is integrative is integrative psychology then an attempt at integrating different such perspectives into understanding of a patient in a richer, more complex way, ultimately almost beyond formulations?
Yeah, I mean, yes, in simple terms, yes. As I've said, the question of horizontal integration is the integration of theory, research, and practice at a psychological level, and the vertical is the inclusion of the biological, the psychological, and the cultural or the social into the formulation practice. So various forms of integration, or integrative practice in psychology, are attempting to do that, but of course, we know that the attempts at integration have been very fraught. So most attempts at integration lapse into kind of eclecticism, and these are the kind of deep clinical problems that we have to face up to. Well, my view, and I think you share this, Nigel, is not that people need to be an expert in every single model. I think that's an impossibility, but rather what we really need is enough models to be able to deal with each of the basic registers of the human mind in a meaningful way.
And different models approach different parts of the developmental task, different parts of the mental operation, different parts of the psyche. Some, deal with behaviour, some deal with bottom-up phenomena, some deal with thoughts, others deal with developmental processes. Jenny's asked a question here. In a singular attempt I've done in a master's assignment using an integrative formulation framework, rather than finding contradictory assumptions, there were wonderful overlaps and synergies. I'm not sure why that was the case, possibly because it was an attachment trauma-based client presentation, something for me to keep pondering as I commence placement and begin working with clients.
No, I mean that's very common that we'll find explanatory overlap. When I was talking about contradiction, most of the contradictions occur at a more fundamental level, fundamental assumptions which become contradictory. But in order to resolve that, what's required is a kind of meta-theoretical stance which is able to integrate those things more broadly, which is exactly what Nigel was talking about.
Next slide, Jan. So some of the errors that are typical for people in formulation trial.
Yeah, I mean, we don't need to run through all of these, but this is just what the research shows, is that there's a number of basic cognitive errors that are very common in formulation. And so things like anchoring errors are very common. So this is where you rely too heavily on the first piece of information that you get. And so often what will happen is someone may come in and initially be describing their experiences as being anxious, and so you'll just hold on to this question of anxiety, and what you'll have missed is the whole backdrop of trauma which sits underneath it. So that's just a classic example of an anchoring error. I mean, the availability heuristics, this is a common one for therapists. This is where you might overemphasize certain kinds of conditions or dynamics because you've encountered them a lot. So it's really common for someone to go and do a special training or a workshop, and then they come back the next week, and all of a sudden they're seeing all these problems, within that model or within that perspective, and that's an example of an availability heuristic error. So there's lots of these. I mean, I don't know that we need to go through them all in detail, but it's just to show that, like any area of psychological work, it's really important for us to be aware that our capacity to think and our clarity of thinking is really the critical factor in the efficacy of the formulation process. And so being able to exhibit enough self-awareness to be able to navigate these areas is a really important part of being a good formulator.
Next slide, please. So the ethical consequences of formulation, why does all this matter?
Yeah, well, I mean, I feel very strongly about this, Nigel, as you know. I mean, my view is that if you can't formulate, in essence, you can't really treat. And poor formulation leads to misdiagnosis, it leads to, ineffective treatments, and which in and of itself is a kind of ethical problem. And so it's really, really important to recognize that if we're not doing this job properly, like if this is one of our responsibilities as clinicians, is to really spend the time to get good at this to be able to help our patients. And if we're not doing this, then we're not really living up to an important part of our role. And again, that's not there to point fingers at people, because I know how difficult and hard this is to do. It's just that we really need to work together as a
It's really about kind of an integrative approach, isn't it? It's about understanding and really kind of working on developing these skills so that the work we do, whatever modality we're operating from, is done optimally, that our outcomes improve,
that's
that
right.
our confidence in the way that we work improve, and that the public generate greater degrees of trust and confidence in the work that we're all doing. And we all know how difficult the work is in what's essentially an emerging sector.
Exactly. And so, what we really need to focus on is not so much the problem, but is the answer, of course, and how we answer this is really the focus of what we're here tonight for.
Next, thanks. So moving towards better practice. And here's a series of points. Psychotherapy integrates science and art. It's not purely a scientific endeavor, but needs to be informed by science. But there's also an artfulness to it, which comes through experience, comes through confidence, and comes through a capacity to really understand your clients well, and then to apply the treatments that you're trained in to those client needs in a very, very targeted way. Is that how you'd see it, Charles?
Yeah, absolutely. And the process of getting good at this, this slide is a good example of this. It's not a one-dimensional thing, okay? Is that we need to really understand how formulation works. We need to develop these analytical, intuitive kind of capacities into a holistic process which feeds back on itself. We need to see this as an investment in the being of the therapist. Increasing the psychological mindedness of the therapist becomes a really important component of the work. And then what we need is, some kind of meta model, some kind of common factors approach that allows us to formulate in our school, in our model, in our approach, in an integrative way, whatever it is we're needing to do. We're really hoping to just help people get better at that. And that's just so important.
Yeah, thanks, Charles. Selena, I'm interested if you have looked much into the impact of broader organisational systemic factors on the ability to enable good formulators. I work clinically in out-of-home care and find that I'm often needing to justify spending my time on formulation. I
Yeah,
mean, totally, isn't it, Trail? Systemic work is one of the things that gets missed when we start talking too narrowly in our formulation, because it's the systemic that often creates the etiology of a later emerging problem.
Yeah, exactly. And I couldn't agree more with this as something that we need to educate people on. One of the things is, formulation is not particularly sexy, I guess, as an idea, but it's just so critical and invaluable. And the fact that you have to argue the time for doing your formulations is a real shame. And I'm sorry that it's like that for you, because we really need to change the terrain around this and see this as a really important part of our clinical work. And it's not a secondary add-on. It's not something that we do when we can. This is a central and important part of what it means to practice clinically. So, yeah, I really support that view.
Next slide. So just to wrap this up, Trail, and then we'll close the slides for a moment and just take some questions.
Yeah.
So why is the patient presenting in this way at this time, which is the koan you'd mentioned from Graham Smith.
Yeah, I often think about it as a kind of clinical koan, because, where do you start and stop that? I just think it's such a powerful consideration. We're trying to get a subjective account of that in a meaningful way. And I guess the thing that I kind of want to point out here is to come up with an answer to that requires us to do something more than just, fill out a template. It requires us to really think about what it's like to be the other person, and try and get into, what the philosopher Thomas Nagel would describe as the what it's likeness of that person's experience. And that's a real challenge. And, if we can just kind of take a moment here just to give it just a rough outline, the apprehension of the subjectivity of another person is always going to be a difficult thing to do. And one of the things that I always say about formulation is it's always a Beckettian failure. Fail again, fail better. It's always incomplete, and we should never take it as a accurate and totalized account of the person. We should be assessing it in terms of, is it useful? Is it providing a useful feeling for the patient? Do they feel better understood because we're understanding them by using our research and our theories and our models and all our studies in order to really grasp the experience?
Thanks. I think you can turn these slides off now for a moment. General, we'll just take some questions from people. I've got one here from Belinda. Anchoring effects are often seen when conducting short emergency assessments within an emergency department, which is often how some consumers are then treated under the Mental Health Act of 2022. Do you not see this as a key feature that should be included in the educational development for RPNs, social workers, OTs, psychologists, and registrars within the public health service to decrease the use of involuntary treatment orders? Oh, hell yes. We see, kind of the consequences of poor conceptualisation in our work all the time, and the lasting damage that can be done from, radical interventions for people that are misdiagnosed.
Thank you. That reinforces what I have worked for many years. I am not on camera, but it's something that I perpetually fight against with my colleagues in regards to trying to tell the whole story, not just what's perceived.
Correct. Yeah. That defined Michael White's work when he began working in the mental health industry around restitution of people's personal narratives as a way of drawing them out of institutionalized labeling as the condition. I think Trail and I both done quite some work with Michael, who sadly left us way too young. How important is case conceptualisation in brief intervention work? Or if your service only allows you to have a short period of time with a client, how can you be efficient if time is of the essence?
Well, I mean, formulation matters no matter how long or brief the intervention is. I would encourage the brief intervention to be addressing the first phase of any treatment, and so it's really important that we hold that view, whether we're doing short-term intervention or long-term interventions, I would have thought.
Thank you.
This is
From
a great question here, Nigel, from Naomi. From your perspective, what is the gold standard framework and case formulation? The 5 Ps? Question mark. So yes, I would say to you that, for example, there's no research into the efficacy of things like the 5 Ps improving people's formulation abilities. In fact, I would say that as a general rule, it makes people worse, not better. The gold standard for formulation, in my opinion, is a formulation process which develops the clinician and develops the clinician's ability to develop formulation. And so if I'll just outline this in brief, rather than this being a particular kind of model, we can think about this as a framework of formulation. And what Graeme and I did is we looked at and we tried to dissect what are the characteristics that are common in all formulation, and how do people do whatever area really well. And so the first area of good formulation has to involve data collection. It has to involve the accumulation of data. So subjective and objective data has to be gathered. If you think about this, we're talking about the relationship here between information ecologies and thinking tools. And it's very hard to use your thinking tools if you don't have good data to think them through with. So the first thing is data. And if we look at, various clinicians and disciplines that are very good at data gathering, psychiatry, clinical psychology, those areas, they do a lot of really good work in gathering data, whether that be objective or subjectively based data, whether that be assessments, whatever it is. There has to be a really strong effort at gaining a broad piece of information. And that includes a clinical interview, which describes the patient's experience in their own terms. And here, the work of Harry Stack-Sullivan is still a kind of standout kind of area. So that is the first point. The next point is an area that is often underdeveloped. And this is the most frequently underdeveloped area, though the research shows it's the most important area, which is the use of what we might call type 1 thinking. And this is intuitive thinking. And it's the role of intuition in clinical formulation. And what we know is that the very best clinicians have very rapid, immediate type 1 thinking, which is pattern recognition orientated. They're using these very, very fast psychological processes. And Nigel, perhaps you can speak to this in terms of how much more rapid the parts of the nervous system that are going to be engaged here are, but they're very, very rapid, and that has to be utilized in order to form what we call the embryonic or the intuitive hypotheses. Do you want to say a little bit about that, Nigel?
Yeah, it's that kind of intuitive process, that mature intuitive process is really about listening to the bottom-up experiences of your body, and these are experiences of sensate phenomena and affective phenomena and memory, body memory, that are operating 3,000 or 4,000 times faster than thought.
That's exactly right. But
married with the top-down consideration of logic and reason. So what you're creating as you develop your skills in formulation is this kind of internal reflective ecology where bottom-up phenomena that you're experiencing are being trusted, not doubted, as we're taught to do in most of our formal educational processes. Get it right, don't feel into it yourself. So getting this kind of marriage of the bottom-up phenomena and the top-down phenomena, all our learning, our educational processes, without privileging one over the other. And what you're doing is developing this kind of circularity inside yourself, which also then has a kind of quality of being circular with the client as well. So you're understanding their inner world, their lived experience, whilst marrying and measuring your own kind of processing. That's, I guess, what we're talking about when we're talking about the art and science of psychotherapy.
So I think that's really important, this intuitive hypothesis formation, which is non-technical. People struggle with this a lot. They at the data collection phase and the intuitive hypothesis phase, what you'll find is that people often bleed in theoretical assumptions already. So they haven't really gotten to the point yet, but they kind of do it too early. Nigel's using this top-down, bottom-up metaphor. you could also equally take a kind of McGilchrist point here and talk about right to left and left to right, hemispheric orientation, because the next phase, and Nigel's kind of alluded to this, is then what we call technical hypotheses. And this is where you use models, theories, research, etc., to give an account of your intuitive response. And this is where we get into this exchange process that Nigel was talking about, where type 1 thinking is interrogated by type 2 thinking. And this is a very important component. Now, if we then move across, what we'll have is normally a number of technical hypotheses if we're using an integrated hypothesis model, or if we're using a singular model, we'll just have one. But if we've got an integrative hypothesis model, then what we need to do is engage in a deselection process. And so this is normally done by 3 basic filtering questions: goodness of fit, utility, and parsimony. And so we'll exclude the theories that don't particularly work well or don't add particular value based on those 3 suppositions. And then we get to our integrated hypothesis, which is a narrative. And, I've tried all the different ways of doing this. I've trained people doing this thousands of different ways. And ironically, telling the story, utilizing human beings' capacity to narrativize, is the best way of blending the top-down, bottom-up, left-to-right processes. And so we tell a story through the theories, through the models, where we're trying to explain the person's experience in a deeper and more full sense using our training.
Ward, you've got your hand up patiently there.
Yes, I just was curious, based on the deselection process and all those steps that you've just covered, is at which point in the process of formulation might you bring metacognitive skills? I'm just asking because I've just been deep in your training model, and just that, where might you sort of bring questions to the patient and then make it a bit more relational as a way to refine and adjust?
So they're 2 different things. The metacognition needs to be online the whole time. This is a reflective process that's being engaged the whole time. Once we have the integrative hypothesis formed, then the next step is a collaborative hypothesis that we share with the patient. And this is the Beckettian failure. This is where we don't mistake the map for the territory. If we think we've come up with this brilliant hypothesis and it's very elaborate, and we share it in non-technical terms with our patient, so we're not babbling them, with jargon and stuff, we talk in very direct terms, and they turn around and say, no, that's not it, then that's gone. But what the research shows is that good formulators have a capacity, what Graeme has called an uncanny ability. And it's an ability to almost hit a bullseye. That when you formulate in this way and you get good at it, what will happen is person will say, you understand me.
Seen, I felt heard. Yeah, exactly.
And so what's really important here is to understand that the formulation is not prior to treatment, it is a component of the treatment. If the first condition of healing is being understood, the formulation is a chance to do that. And so we do that piece there, and once we have collaborative agreement and we feel like we're on track, if it's not, we revise the whole process and we start again.
It's important, isn't it, Trail? When we're offering these kind of collaborative formulations, these kind of metacognitive offerings to the client, they need to have an affective life to them. There needs to be something that connects that right brain to right brain, kind of McGilchrist around just really, really connecting with the people.
Yeah, they feel
if it's a sterile kind of collaborative piece, then people won't resonate with it. This is work that's done in all of the metacognitive and mentalizing practices.
Yeah.
There's Bateman and Fonagy offer this kind of approach. DiMaggio and the various Italian works in metacognitive therapies all use this way of engaging the client or the patient in a relational frame with you.
Yes.
People feel heard when you feel their feelings with them.
Yeah, and often there's a sense in which you're able to articulate something they have not necessarily been able to articulate fully themselves. And so that component of the formulation is very important, and that then is how we arrive at our treatment plan. And that gives us then a collaborative agreement about what we're here to do and how we're doing this. And this takes us all the way back to the kind of classical analytic notions of building a therapeutic frame, where now we're really clear about what we're here to do and we're doing this together. And, you know, we've really brought our training and our abilities together to help the patient in a meaningful way. So I thought it'd be useful just to outline that in, you know, dot points, just so people get a sense of, rather than espousing a particular model or a particular template, what we're really talking about is those things are essential in all good formulation. Some people will do it all explicitly, some people will do bits implicitly. But what we want to do in the training environment is take each section on its own terms and help people get better at doing each of those things. So how do we get better at doing the intuitive component? How do we get better at doing the technical components? How do we get better at the deselection process? How do we get better at doing a collaborative formulation? We want to take each step and we want to support everyone to do that, because these are tangible skills that we can improve on.
And in response to your question, Maud, you know, the mentalizing skills are a constant part of that process, and the metacognitive view we take is exactly what we're aiming for in that work. Marie asks, what are the qualities which you consider make a good formulator? Intuition and accurate reflection seem vital to reach a collaborative way forward. Exactly, Marie, that's exactly what it is. And, you know, also, I think a good formulator trail would be someone who has an active curiosity, who's constantly generating more knowledge, that's curious about different you know, techniques, wants to really kind of integrate those techniques, you know, as Jung would say, you know, make them your own and then forget about them. You know, it's that real quality of accumulating curiosity without it feeling like it's a pressured, I don't have this, I must get that. It's more, you know, just taking that kind of speculative approach to the work.
I might extend that by saying that a form of epistemic humility is really important. There's a kind of humility about the patient being the expert in their experience, and we're in the privileged space of hearing that. That to me seems very important. But yes, the intuitive component is important, but it's not more important than the analytic component. You know, if you don't have a strong grasp of theories or models or research, it becomes impossible to think through them. And so it's really a question of identifying where everybody is as a formulator. Yeah, so it's like, you know, some people will be really strong in one area and need support in another. So when we're doing supervision with people, it's not that you have just this generic thing that people have to do, is that what we have to do is figure out where are the strengths in a particular person's formulating capabilities and where are the weaknesses, and when we're going to amplify the strengths and support them to develop the areas that were weaker, and that will improve their formulation capacity more generally. And so I would see all of these things as important, and people can struggle with all of them and some of them, but most people have some difficulty with the process.
Is there anything that you recommend to improve the intuitive thinking skills, pattern recognition? And I think that's Isabella. And I think it's really a matter of just learning that place of trust, humility, practice, and, you know, that constant, you know, looking to the expertise of your clients and patients to see if your thinking is being mirrored by their experience. You know, I think that's the best way to develop your intuitive faculty, is trusting the skill of the patient.
Well, but I think the best way to develop intuitive thinking clinically is to explicit and not an implicit component of your formulation. So a lot of people do it implicitly. They're like, oh no, I just do analytic thinking. I don't do intuition. But of course, everyone is already thinking about a patient implicitly the moment they hear about them. And so the most important dimension is to transition that from the implicit to the explicit and be like, all right now I'm engaging in the intuitive component of the formulation. What is my gut feeling? You know, I've just, the paper's not published yet, but I submitted a paper recently where I talk about hunches and grasping and nousing and these other kinds of ideas. And, you know, it's really about developing a sophisticated ability around those components that you really have to kind of get a sense of. And if you do that, you'll notice that you arrive somewhere in pretty short order where things will be pretty improved pretty quickly.
I'm conscious that we're really coming to the end of our hour. Kwan here says, formulation sounds like it helps clients own their story, making sense of their experience with guidance from the clinician. Exactly, Kwan. Yeah, that's exactly what it is. Maria notes that she uses outcome rating scales and session rating scales to help with formulation and treatment. That's a great way of, you know, kind of engaging the client in the process. And, you know, that's the Scott Miller material and other people that have worked on that. I think that's a very helpful way to kind of integrate and support the work. I think we're pretty much out of time. So there's a few more questions, and I'm sorry we haven't got to everything. Gina, if you just want to put up the last couple of slides. No, just one back. So what you'll gain if you enter into a more kind of formal arrangement of training with us, we've got a workshop coming up, and you know, we do these regularly, and we believe that case formulation skills are both identifiable and teachable, and I hope that you've got a bit of a sense of what that looks like tonight, and a sense also of how these skills will improve your client engagement, how they'll improve your treatment planning, and support whatever modalities that you're working in. It's not about, you know, kind of another different mode of working. This is what we're interested in, is the meta psychologies and the meta approaches that help us do whatever work we're doing better. These skills will improve your outcomes, irrespective of the techniques you're trained in addition to those. So the final slide.
Just as an addition to that, Nigel, just people who may want to come along to the training will be 2 days, and we'll be building up some of these ideas a little bit more thoroughly. But one of the things that's really important, that if you come along, we'll ask you to bring case material, and we'll engage in formulation practice as part of the workshop. So it's important that we actually see it as a kind of experiential skills-based training. So just wanted to flag that for people, that will be a component of the training if people want to come along.
And if people have got questions, please reach out to us at Training of Integrative Psychology. If you've got questions about things that we've covered tonight, or questions about that we haven't had enough time to adequately answer, you know, we're really very committed to supporting the development of conceptualization skills within our clinical community, because we believe this is the path forward to help our community, to really help clinicians understand how to conceptualize, how to think about treatment, and therefore how to do it well, how to do it accurately, and enjoy the work you're doing.
Yeah.
Goodness sake.
Great. Thanks so much.
Thanks for joining us, everyone. Good to see you again, Trail, and thanks for joining us wherever you're coming from. Lovely to see you all.